Dr. Jacoby, the question I get most from the people who come to our dinner lectures, and I hear it all the time, is tell me about the actual examination. Even if they've thought of the things that you've told us about, they don't actually know how to examine the patient to come to these points. And I think it would be very helpful if you could illustrate for us how a physician would actually do this.
I'd be happy to. Tim, first thing I want to do is go over the anatomy. This exam that we use is based on A. Lee Dellin's exam from Johns Hopkins. He's a professor of neurosurgery and plastic surgery. And he came up with this exam. This is the head of the fibula. The common peroneal nerve comes across the leg about this section right underneath the bone. This is a common place for compression. If I press on this nerve, we'll get a wince if it's positive. If it's not positive, there is no reaction. When the next nerve is on the top of the foot, which is called the deep peroneal nerve, when we press on this one and we get pain, that's considered a positive provocative sign. The second thing we want to do is tap on the nerve. On legs that are fairly thick, it's difficult to get a positive Tinel sign, buzzing or tingling of the nerve. You can get it fairly easy on this portion of the foot. Now, the third set of nerves on the lower extremity is part of the tibial component. The tibial component is the posterior tibial nerve as it comes down into the foot and divides in the medial and lateral plantar nerve. And there's also a sensory nerve that goes to the heel. When we press on this nerve, or this nerve, any one of these branches, if it's positive for compression, then we're going to get pain. If we press on the nerve and there's no response, there's no response. Some patients will ponder the answer. That's also negative. They have to have an actual wince, and you have to look at their face to see if they're constricting their eyelid and their eyes. And that's a positive response. So we had the provocative and the Tinel sign, the two most important measurements clinically for nerve compression. Now, the traditional approach has always been the Semmes-Weinstein monofilament and see if the patient could feel 1- and 2-point discriminatory changes. That is negative even in patients who have ulcerations. Dr. Dellin and myself did a multi-center study on that, and we had ulcerations. They could still feel that. The percussion for the patellar response and the Achilles response are really late phases of large fiber neuropathy. By the time this is not responding, this disease process is well established. The use of tuning forks is also a late stage. This is assessing whether or not there's a waveform going through the whole leg. It does nothing to pinpoint the exact nerve that is involved. Nerve conduction at this area and at this area on the other leg or the top of the foot is the most important test, nerve conduction velocities, both reduced amplitude and increased latencies. They're the most important. Muscle testing is also done. If there is a loss of spreading action in the toes, that's an indication that the intrinsic muscles are not functioning. That's part of the tibial nerve. If the great toe is weak against resistance, then that indicates that the leg muscles are not functioning. If all these tests are negative and they're still burning and pain and the pulses are good, then an epidermal innervation density biopsy is the best test. Take a small piece of skin, we send it to a specialized lab, they count the number of the unmyelinated fibers. They're the first ones to go. And then you can make the diagnosis of small fiber neuropathy. This test and the nerve conduction are for large fiber neuropathy. So to summarize, when a patient complains of pain, burning, numbness, claudication type symptoms, you have to rule out arterial disease. First test, do they have pulsations? If they do, press on the nerves. If they're painful, then go look for nerve compression. The venous filling time is pressing on the skin to see if it fills. That's a late stage arterial disease. So most patients who present with pain numbness, tingling, burning, all those symptoms, it's either arterial disease, venous disease, or neuropathic disease. But in the diabetic population, it's going to be 10 to 1 neuropathic disease over arterial. Thank you.